Thank you so much, Professor Abdallah, for this nice and kind introduction. Thank you, Dr. Rosano, for inviting me for this excellent meeting once again. I'm here to compliment my colleague, the cardiac surgeon. We're doing the same job together in different ways. My role today is to discuss the role of PCI in the treatment of heart failure, when and how. Well, before I go into my topic, I would like to remind you with a terminology that appeared 4 decades ago, myocardial hypertension. It was suggested by Dr. Rahmatullah, describing a status of chronic myocardial ischemia, which is an adaptive state of left ventricular systolic dysfunction, which could be completely recovered with revascularization. And those observations were supported by recovery of the left ventricular function after coronary bypass surgery. From that time, for the last 4 decades, revascularization has been the goal of recruiting hyperkinetic myocardium and has been the key component of the management of chronic ischemic heart failure, although the evidence for randomized controlled trials are not available till recently, and that's what I will discuss with you today. The first study is a surgical study, STITCH study, and STITCH extended trial. The surgical treatment for ischemic heart failure trial randomized more than 1,200 patients with severe left ventricular dysfunction. 5-year survival showed no significant difference. However, 10-year extended follow-up demonstrated highly significant coronary artery bypass surgery superiority over optimum medical therapy alone. But there are key patient predictors here. First, the long-term therapeutic benefit of surgery was not uniform. The survival advantage of bypass surgery with optimal medical treatment was most pronounced in younger patients, less than 60 years old, and those presented with greater baseline severity of left ventricular dysfunction. On the other hand, the revived trial randomized 700 patients with poor ejection fraction and extensive coronary artery disease to either PCI and optimal medical therapy or OMT alone to evaluate if percutaneous revascularization would match the surgical efficacy with low upfront risk. As we know, the risk of PCI is a safer procedure. And we have to highlight that 97% of the patients received modern drug stent. They used drug-eluting stents, and the procedure success rate was quite high, 98%. And of course, medical therapy was done a recent study, so the medical therapy was better than the medical therapy used at 10 years ago with surgery. This table shows the difference between both studies. The primary endpoint was all-cause mortality for the surgical trial, but mortality and hospitalization for the PCI, short-term hazard, early mortality in the surgery as expected due to surgical morbidity risk. It was extremely safe procedure in PCI, was low early hazard. Ejection fraction was substantially improved over medical treatment in the surgical study. However, there was no significant difference in ejection fraction recovery versus OMT in the PCI study. The quality of life sustained long-term health improvement in the surgical trial. There was early benefit with the PCI in the first 6 to 12 months, but this was lost by 2 years. But we have to put in consideration that the long-term follow-up was 10 years with the surgery, but only 3.4 years with the PCI, quite short in comparison to the surgery. We have to put many concerns in position. The UK National Health Services studied these two studies from the cost-effective point of view and quality of life, and they ended up by showing the cost utility of PCI and OMT to be higher than OMT alone, with no significant difference in improvement of ejection fraction or quality of life. So PCI does not meet efficiency threshold according to their analysis. However, when we look at the economic aspect of both, we can see that the surgery cost-effective ratio was $64,000 per QALI over a lifetime horizon. This places surgery squarely within the range of intermediate value healthcare intervention in a country like US and in the global health system. In contrast, the PCI-OMT is a dominant therapy, higher cost, but equal or even less efficacy than medical treatment. However, when we analyze these two studies, we have to put some important points in explanation. First, the market age difference. The revived patients were older, 70 years or older, while in the STITCH study, the patients were younger. So the long-term surgical benefit was concentrated mainly in patients less than 60 years. But the older patients did not benefit with surgery, similar to PCI. Also, there was varying ischemic burden. 63% of the population of the surgical trial had symptoms of angina, while 66% of the patients who underwent PCI had no angina, suggesting that severe left ventricular dysfunction was out of proportion. Also, the medical treatment was more advanced with the PCI study than with the surgery, and CABG avoid any future problem in the proximal part because the surgeon bypassed any obstructions, so that reduced the long-term myocardial event. So recommendation from all these studies that medical treatment is a must, and it should be the first step in the treatment of patients with left ventricular dysfunction, heart failure. Consider coronary artery bypass surgery for purpose of survival in young population less than 70 years old. PCI should be strictly reserved to symptomatic patients. Patients should have anginal symptoms and or not surgical candidate rather than routine strategy to improve prognostic or mortality outcome. Quickly, I will go over a case report with this meaning. Patient 72 years old, multiple risk factors for coronary artery disease, multiple PTCI, comes with acute coronary syndrome, anginal pain, ST changes, congestive heart failure, and the patient, as you can see from the clinical exam, is in tachycardia, hypotension, bilateral basal crypts, troponin is high, creatinine is high, CKMB is high, BMB is high. So this patient is a good candidate for intervention according to the criteria I just presented. After he was put on optimum medical treatment, his echo showed segmental motion abnormality with ejection fraction of 30%. This is his angio showing bifurcation equivalent left main stenosis with significant lesion in the proximal LAD and circumflex artery. The good thing is that the stent did not show residual instant restenosis except for the distal LAD here. Even a small stent in the OM was fine after 11 years of the procedure. So, to make a long story short, I will not go over the details of the technical aspect. This is just to go to the final result. We fixed his coronary using the decay crush technique with modification of the plaque because of the calcification with lithotripsy or IVL with success, and you can see the result. The patient did very well after that. His symptoms improved, and he was able to walk without chest pain for the first time, discharged in good medical condition. This is, if I have just 1 minute, please. Can you give me 1 minute to conclude? Thank you. So you can see this echo was done like a bit over 4 months post the procedure, and there's significant improvement in his ejection fraction. It was estimated to be 53%. So in conclusion, congestive heart failure is a common complication of chronic coronary insufficiency, what we call hibernation. Early initiation of modern anti-failure medications, what was discussed during the day today by many of my colleagues, prevent deterioration of the heart function and expedite recovery after revascularization. Evidence of viability and or ischemia is warranted. If the patient is not in acute coronary syndrome like in my patient, and you have time, you can do viability study or ischemia study to make sure that there is viable myocardium. And finally, revascularization, cardiac bypass surgery for survival, PCI for symptoms is the ultimate goal for revascularizing and improving left ventricular function for these patients. Thank you so much.
Excellent.